Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have an exciting session with Dr. Raskin. Dr. Raskin, thank you so much for joining. And on that note, the floor is yours to take away.
All right. Thank you, Isa, and thank you, Dental Shadowers, for having me. I know we've had a few hiccups trying to get this meeting going, but I'm happy to finally be able to meet with you all. And I hope that what I share today either introduces you to perio or gives you some more insight into what periodontics is and why I think, or why I'm even deciding to pursue this specialty and why I biasly think it is the best one in dentistry. So let's just jump into it. Just to go through a quick agenda here. So basically, I'll just talk to you guys a little bit about who I am, why I chose dentistry, and then why I got into periodontics, what it's like to be a resident currently. I'll show you guys a couple of cases, and then we'll finish up with some Q&A final thoughts. Okay, so first, just a bit about me. I'm originally born and raised in Miami, Florida, and I went for my undergraduate. I went to University of Central Florida. Go Knights. From my understanding, you all watching are from all over, but I know there are some people from Florida specifically. So it's hopefully this is like, helpful for you all to hear from in terms of my trajectory or how I sort of worked my way from Florida out into where I am now, Philadelphia. After that, I went on to dental school at NYU, and now I'm a second year resident at the University of Pennsylvania, which again is in Philadelphia. So just to back up a bit, how did I even decide to get into dentistry? Well, when I started, when I first started undergraduate, I entered in a pre-med mindset. I'm sure there could be a lot of you that are feeling similarly. I told myself I'd keep an open mind, but I did go in thinking that I was mostly leaning towards the medical side of things. And so at first, I joined a group called PPMS, which is the Pre-Professional Medical Society at UCF. And that club is really great because they don't just cater to one sector. So it's pre-med, pre-dental, pre-vet, pre-farm, you name it, we have it. And it was a really insightful way to learn about the different options and different careers that you can get into um, within the healthcare field. From there, pretty much what happened was I remember being actually a sophomore and it was summer break and I took my sister to the orthodontist and I'm sitting in the waiting room and kind of had an aha moment and thought to myself, I've never even truly considered dentistry. We did have at that point, in that point of me being a member of PPMS, we had a dentist come and speak and I thought it was kind of boring to be honest. But in sitting in that waiting room, I kind of realized I didn't consider specialties. And so I asked my orthodontist, do you mind if I hang out with you the rest of the day? He said, of course, no problem. So I bopped around with him and I really loved it right away. I liked that it was very hands-on. I liked the dynamic and the relationships that he had with his patients. So at the end of the day, I remember saying to him, Dr. Briani, this is great. I think this is what I want to do. And he said, well, that's wonderful. However, you need to go to dental school first and then you can specialize. And that's how little I knew about dentistry because I did not realize you would have to go through that process initially. And so he said, I recommend you go shadow your general dentist to get a better idea of what you'd be in for before you even consider ortho. And who knows, maybe along the way you'll change your mind. And here we are today. So sure enough. But I went ahead and took his advice and I just shadowed my dentist for an entire week. And each day that passed, the more I realized how much I really am interested in dentistry and how it is such a fitting career for me in terms of what I'm looking for. So first and foremost, I'm helping people. Second, it's very meticulous work, very hands-on. We work within millimeters. That's your eyes are trained to just notice the little details and to be very intuitive. And the treatment planning and diagnosing that goes into it to me was very interesting. And third, the lifestyle is much better than having some, to be candid, some crappy on calls at 2 or 3 in the morning. So that was also nice. I love the idea of having a relatively normal life in terms of a 9 to 5. And then once I realized that, I went back to school, finally feeling like I had a set plan. And so when I got back to UCF, I said, okay, I'm going to stick with PPMS, but I'm also going to join PDSA, which is our pre-dental organization. And I'm going to get into leadership because one of the biggest tips that you all, I'm sure, are aware of, and that I learned early on starting college, was that you need to, it's great to have the good grades, but and do well on the tests, but that's not enough. You need to set yourself apart in other ways, particularly leadership, philanthropy. Those are the things that schools really want to make sure that you're focusing on. And the point in that is just to show that you are a well-rounded person who is not just going to check the boxes of what they have to do. They're going to go above and beyond and try to show that they can achieve more. And so I became director for both those societies, and it was great because it's great to be a member of a group, but when you take on a leadership role, it really pushes you to show up, essentially, because now people are depending on you for whatever that role is, entails, that you've signed up for. And it's going to help you actually get to know yourself a lot better too, I think, because it starts to teach you your teaching style, your leadership style, what you do and don't like, what clicks for you right away, the things that you realize, I do not enjoy this, I don't want to have to be responsible for making social events if you just really don't like to plan it, you just rather show up, or being the person responsible for creating some sort of mentorship relationships. Or maybe you realize, I absolutely love this, this is a great chance for me to network on my own, and I'm helping others create networking opportunities as well. So I highly encourage you all, if you're not already, to go into a lead, or seek to also be a leader as well, even if it's something simple. I mean, you don't have to go be president of 3 clubs. You can do something like I did, which I was director overseeing a few sections within the club, if you will, or even less than that. You can just help out someone who is a director, or whatever terms or positions, names they call their positions. But regardless, I just think it's worthwhile to have that factor help you stand out. And jumping into dental school. Okay, so basically I decided I wanted to do dental school. I do the leadership, I jump into the leadership opportunities I could find. I studied really hard. I made sure I had the grades I needed, and the scores I needed to get myself to a place where I can have ideally options. And I had a really nice experience, thankfully, where I applied to not too many schools. I know that's always a big question people ask, is how many programs did you apply to? Keep in mind, you guys, that I applied to dental school back in, was it 20, I guess it was 2015 during the application cycle. That's crazy. That's so long ago. But back then, the numbers, I don't know what they are nowadays. I remember thinking a lot of my friends were applying to 15 schools, which I thought was quite a lot. So I did not do that. I applied to 6. And again, I had, thankfully, a really great experience. I got interviews for them, for all of them, and I got invitations to attend all of them. So I was in a really unique place where I had the option. And ultimately, for me, what felt fitting, the most fitting for what I wanted, was NYU. Fun fact, if you didn't know, it's the largest dental school in the world. And with that is a ton of opportunity, and a ton of hurdles too, because some people maybe don't feel that they do so well in large class settings, and maybe some people thrive off of that. I felt that I really liked having that range of resources, because there are so many people in the world for us to learn from. And you can kind of get stuck, in my opinion, you can kind of get stuck in a little bit of a bubble if you only see and know this small subset of what you're looking to learn and expand on. So with NYU, again, we have the largest school. We had every specialty. Literally each floor is a different specialty in the dental school in the building. And we have a lot of world-renowned clinicians coming in, whether it's just to lecture once a week or once a month, or maybe they're teaching there all the time. There are some really unique people there, and special people. And I feel very fortunate to have those be my mentors. I was surrounded by who to this day I still look up to, still speak to, and would not be where I've gone to today without them. So I think it's worthwhile to consider in terms of dental schools and where to apply. I mean, I've had such a good experience at NYU. I can talk about it all day. I won't, but if you guys have specific questions about it, I'm happy to answer. And while I was there in dental school, I kind of continued on that track of leadership. Now, I knew even since high school that I enjoyed being in clubs and kind of climbing the ladder and having leadership positions. I really enjoy it. I think that, again, it pushes you to work a little harder because expectations are put on you, responsibilities are put on you. And I think it brings out a really nice version of people to see how they become pretty selfless because they're prioritizing this group or this goal, uh, whatever that may be, to have to end in the best possible way. So I dove in. I mean, you guys can see here, I listed everything I did, and this fight hopefully doesn't come off this way. By no means is me trying to boast. It's more to show you that you can do a lot. You can do a lot of it. You can do one of it. You can do none of it. It's ultimately up to you. But in dental school, I know this is true for NYU, and I know this is true for pretty much any dental school. Uh, that there are a lot of different types of ways you can get involved and find your niche and grow with it. Specifically with ASDA, I had such a great experience. You guys may or may not know this, but ASDA is the American Student Dental Association, and every dental school has one, has a chapter. So I hold quite a few positions in it, kind of, again, climbed the ladder from a D1 up until D4. And in doing so, you should be, hopefully, ideally, if you're involved, you're attending the conferences. That's when you're getting to meet people, dental students from literally all over the country, making those networking connections, starting to get an idea of what, kind of where you want to go in the career, what the career can do for you as a clinician, how you're going to be able to better serve your patients getting out of school. It really is such a special club, and I encourage you all, once you're in dental school, wherever you go, to join your chapter. Um, just going down the list here, I guess, with Dental Economics Club, unfortunately, we're all going to be, or can't have the potential to be, small business owners, but we don't necessarily get the proper training for that. And nowadays, you hear a lot of conversations about corporate, and that's great. It is true that there's a model in place to help you not have to worry about the business side of things. But if you do, or if one of your ambitions is to ultimately own your own practice, that's its own hurdle. That's its own lesson to be learned. And I realized that within dental school, with our curriculum, they're not providing education on that. So with this club, we're able to basically create some, within reason, as much as we're meeting, as much as we know, some guidelines essentially on the major topics. So how to tackle student debt, how to evaluate contracts once you're looking into getting into practice, and contracts could be anything from being an associate to buying a practice. We looked into all of that, and just financial literacy and understanding how to make sure that you are making the most of your yeah, your financial well-being, because we're going into a career that you can be very successful. It is so expensive nowadays. That part still frustrates me. But that being said, you obviously want to be smart about it, and in order to do that, you have to educate yourself. So that was the goal with that club. And if your dental school doesn't have one and you wanted to start it, I think that's an amazing thing, an amazing source to provide to your colleagues. So something to consider there. And then yeah, so class council and alumni relations, I was working within my class just to speak on behalf of my class 2020 when we discuss any things, any pressing issues or ideas we had with academics and the deans. And then with research, I did mostly behavioral research. It was dental fear, and as you all know, I mean, good. The statistic is 20% of people are fearful of the dentist to the point that they won't go at all, and that is just will lead to a domino effect of issues. And the whole idea behind the research is learning how we can better accommodate these patients so that we get better patient retention and compliance, and then the patients don't have to go through potential emergencies down the line because they were avoiding us for so long. So it's some pretty interesting stuff. And getting into residency, I've continued on with some different research. I'll probably talk about it a little bit later. But I do want to be mindful of time for you all because I know that it's late and I appreciate you all meeting here. So let's continue on. So advice, the biggest thing I can say is time management. I mean, I can't stress it enough. If I think given my personal experience and what you guys have learned so much so far from me, or about me rather, is that I do like to juggle a lot of things. That being said, I think I know myself well enough to know that I perform best if I can kind of have these check marks and really just carve out what I'm supposed to be doing when, and I stick to it because if I know that if I don't do it now, I can't do it later because later in that next hour I'm supposed to be doing, XYZ. So for me, there's always like that joke of, I feel like in college we learned about it, but it's like the three triangles, and it's like sleep, sleep, like sleep, study, party, or sleep, study, eat, depending on your preference. In any event, I clearly did not choose the sleep route. I decided to just make the most of the other two. And that required a lot of discipline for sure. But I've honestly, the routine I built in college has stuck with me. I I'm more on the side of waking up early. So I'm up every day at 5:30. I'm either doing a workout or preparing. I mean, not residency versus dental school is different, but just to go up what my days are like right now. I'm waking up early. I'm either working out, prepping for a case, meaning reviewing the CT scan before I have to go in for surgery, or looking at what patients are coming in today. I have my day filled and then come home, have some, personal time for me, which I'll talk about a little bit later. And I go to bed at a decent time, to be honest. I'm kind of a grandma. I'm usually asleep by 10:30, so it works out. But that's my 2 cents to you all, is to just be mindful of how to make your days the most productive and how you can get the most done without feeling burnt out. That's very important. Okay, so let's jump into perio. So periodontics is the dental specialty focusing exclusively in the inflammatory disease that destroys the gums and other supporting structures around the teeth. A periodontist is a dentist who specializes in the prevention, diagnosis, and treatment of periodontal disease and in the placement of dental implants. It also consists of 3 years of additional training after completion of a 4-year dental program. So if you guys are all still awake after hearing that very boring explanation, what were you thinking? Why would you want to ever get into that? And there's a joke where people refer to periodontists as gardeners, and I embrace it. That's fine. But basically, for me, what really sold me on perio was it's the foundation. You're not going to be able to do any good dentistry if your gums are inflamed and your bones breaking down. Nothing's going to hold. You're just going to keep losing the teeth. So you need to have an understanding of it, and you need to have a respect for it, because it's going to help you in the long run be successful if it's in the most healthy state possible. What I also really appreciate about perio is that it's pretty much it would, arguably the branch of dentistry that's the most closely tied to medicine in its most, like, to its essence, meaning anything that we do is based on biology and understanding of the inflammatory process and how it ties into your systemic needs as a whole. And that's important because, again, it's going to influence your treatment plans and your treatment outcomes depending on that patient. So what's fun about perio is that once you learn to love it and kind of geek out on it, then you get to teach this back to your patients. And it's really, to me, so rewarding and so amazing to talk to someone about something that you're very passionate about, and they leave there feeling as passionate about it as you are, because you really have come through to them and made them realize this is important. This is your health. This is your mouth. It's not just a pretty smile. This is how you eat your food. This is how you speak. And if you can't do any, even just one of those things, you're probably not going to have as great a quality of life as you would otherwise if you did have that. And it's, again, rewarding because you're teaching something that's foundational to the patient, and once they have an understanding of it, your treatment's going to go very well. The other big part of it is that perio is actually very, very heavy surgery based. I, as a D1, D2, and I think every D1 and D2 would agree, let me backtrack. You guys might know this already, but just to clarify, because I don't know how much whoever's listening does or does not know about dentistry. When you're a dental student, there's D1 through D4. If you're a D1, you're a first year dental student, and so on. So your first year to dental school is really just didactic. You're just learning everything that has to do with dentistry, every field, every specialty, and every little detail. So perio comes off as that one section or that one exam that is usually the hardest, and no one really gets why the periodontists are so anal and why does this matter? Why do they care about diabetes so much? It's, we all joke about it, and I can also get into why it is so important, but we won't today. I'll save you guys that misery for another lecture if you're interested. But it's once you get past that hurdle and you look at what are these periodontists doing all day, it's surgery. And it's so much fun. To me, they're some of the coolest surgeries I've seen in dentistry, and I have so much fun doing it. It's every time I get ready to go in for a procedure, it's like this fun little sort of like rise in your stomach of just feeling like a little kid almost. Not to be, I don't know if that's maybe weird to people when you start seeing the surgeries that we do, but I don't know, me and my co-residents all agree it's a lot of fun. And it's, you guys will see some photos, but I'll get into some of the details. It's very cool to see what we can do with a tiny scalpel and some sutures. So that's a little bit about perio. I also should have this graph here. The ADA shared this, I think it was 2015. Yeah, this was released in 2015. And this is just an idea on salaries. I thought it was relevant to share it with you all just to give you an idea of what to expect. This is 6 years old now, so you can anticipate that all these numbers are higher for all the respective specialties. I added this to my presentation because I've had people ask me in the past about hearing that it wasn't worthwhile to specialize and no one really uses perio anymore. It's a dying field, and honestly, you'll hear it's a dying field about every specialty from a general dentist. It's not necessarily true. And from a financial standpoint, to me, it made a lot more sense. Well, okay, to me, it made sense to specialize for two reasons. One, because I generally fell in love with perio. I couldn't see myself doing general dentistry once I saw the perio procedures that I could be doing. And then two, with the amount of debt I've already taken on in dental school, for 3 more years and this additional debt, I could potentially increase my income through at least double, if not more, than what I would be getting as a general dentist. And so from that perspective, for those who are very black and white, it made sense to me to just tack on the 3 more years if I know I have this earning potential that's going to be substantially more. So, okay, a little bit about residency. It's definitely exhausting. I don't know what I was thinking when I started residency. I thought it'd be chill and relaxed, and you kind of just go in and do. Now you just, all you have to do is your procedures, and you're not going to be hounded by questions by your faculty. It's going to be so great. It is, but it's definitely not a walk in the park. The days are long. My days are pretty much 12-hour days. I would say 7 to 7, Monday through Thursday. And there's always something going on. You're either having a consult with a new patient, doing a surgery, checking a post-op, running to class, presenting at a seminar. We have evening classes. I'm also getting a master's. A lot of residency programs will have a dual where you can do your residency and get a master's. So I'm doing that. So those require extra classes. And just anything else that pops up in between, right? We have life as well that's happening, and we have to also remember to make time for the things that we enjoy personally. So for me, that's making sure that I'm making time to work out and take care of, sound mind, sound body. It's cheesy, but it's true, and I try to prioritize that as much as I can with during the week, and then I try to make sure I'm keeping in touch with my family and friends and seeing them as much as I can, as much as my schedule allows, and just having fun with it. There's going to be days where you're obviously very stressed out and potentially even asking yourself, why am I even doing this? And then that's the moment you have to stop and take a breath and remind yourself, because this is what you love, and this is, you thought this through thoroughly. You made this decision knowing that you have this goal in mind, and there's going to be days where they're not going to be so great, but ultimately you know that this is what's going to make you happy at the end of the day. And I think just sticking to that mentality and having a positive mindset is really important. Is going to help you get through residency, dental school, college, the application process, the whole nine. I think as a blanket statement, just try to have fun and, laugh about it when it gets frustrating, find the silver lining, but just stay positive, even on the days that it feels impossible. So a typical day, I kind of went through this. Yeah, it's definitely not 6:30. I wish, but no, 5:30. I realize that 6:30 is not cutting it anymore. But anyway, this is pretty much what I just kind of talked to you all about with what you can expect in a day. one thing I didn't mention was, yeah, the actual workup of cases. So cool. You meet this patient, they need 4 implants and they need a sinus lift and they need a GBR and they're interested in maybe having like getting veneers done, but then their teeth are too short. So you have to work all this up. And there's the most traditional ways are going to be, well, nowadays, digital dentistry is definitely what's taking over. And so you have to learn, that's its own sort of craft to master, is how to come from a digital approach with planning versus analog, meaning the uh, the old school way essentially, where you have models and casts and wax ups and things of that nature. So something else to keep in mind that definitely takes up time of its own in your day as well. Okay. Oh, so I actually really appreciated that the DentalShadowers had some of these questions that they wanted me to specifically address. I thought it was really great and important questions to know, at least from a surface level when you're just learning about specialties. But what are some things that patients will come in complaining of? Probably one of the most common is I need implants. People start losing teeth. And for the most part, they'll lose a lot of teeth before they realize I should be replacing these teeth. So that, again, becomes a pretty complex treatment. I have deep pockets. This is yeah, just as just as commonly complained about as needing implants, because these people have periodontal disease. And so you're, of course, going to come to the periodontist to address that. We'll also see, or I'll also find patients complain of sensitivity. It's usually related to recession more often than not. And then just blanket or generic statements, I want to fix my teeth, and they have 2 teeth left. So you have to work with what you're given, but it's, the gamut is never ending, it feels. It's definitely, it's fun. You know, you never what's going to come through the door. You have an idea based on the referral, but when you sit and start talking to the patient, it's pretty interesting what you can fall into. So procedures, definitely implants, and everyone's placing implants nowadays, right? It's general dentists, it's oral surgeons, it's periodontists. I'm biased, and if there's anyone listening out there that's a general dentist or an oral surgeon, um, you know, no offense to you all. I just feel that perio, again, I'm biased, but perio is the best. And if you're going to be doing implants, we are those who focus solely on studying the supporting foundation of teeth, aka the bone and the gum, and what supports an implant, the bone and the gum. So I think that we have the most intensive training when it comes to how to really truly deal with implants, not just putting them in, but maintaining them, saving them when they're not when things aren't going well, when they're failing. It's never ending, it feels like sometimes. Sinus lifts, which are cool. If any of you don't know what that is, essentially your sinuses are air sacs essentially filled, and if you ever need implants for top teeth, a lot of patients could present with bone, very minimal bone, and just that full air sac essentially, where you'd have to physically lift the sinus, pack membrane or pack bone graft, excuse me, and let that heal, and now you'll have enough bone to place implants. So it's a really fun procedure. Hard and soft tissue augmentation, kind of generic term for just building up areas. So sometimes, again, you want to place implants and there's not enough bone, so you have to start growing bone with graft materials. And you can do similar procedures with gums. So whether it's a gummy smile, you need to get rid of it, or there's recession and we're trying to get it back. Soft tissue plastic surgery is kind of going into the recession, as well as what's called aesthetic crown lengthening. So people that smile and they say have a gummy smile, there's procedures that you're not only involving the gum, but also the bone, and repositioning things in a way that now the teeth look longer. Resective procedures, that's going to be most traditionally something called osseous, where you're basically recontouring bone if someone's presenting with persistent deep pocketing that's not going away with a deep cleaning. It's very common. Probably one of the first procedures ever performed with perio. And then regenerative procedures. So, you know, the more time passes, the more studies that we have and more research that comes out, the more we're learning on how we could actually try to regrow things. And that's a lot of fun, and probably the side of things I'm most interested in, because we're using a lot of different biologic materials that are helping not only recreate the bone that's been gone, but even some of the supporting structures. So something called GTR, which stands for guided tissue regeneration. We can regenerate the bone, the ligament, and that and the cementums. These are all portions of that are normally part of a natural tooth. So I think it's pretty incredible that we are finding ways to bring that back. That's not something that always existed, and every day they're coming out with something new and something better. So it's exciting to know that the field's headed in a way that will hopefully not have to even ever remove bone again at one point and just be able to regenerate. That's where it's headed. So some diagnostic tests and instruments that we use. Basically a comprehensive periodontal examination. When you do that, if no one's shadowed yet and really has no experience at all with perio, at the very least, hopefully your dentist has done this to you, but you have a probe with measurements at the end of it, and you're just going inside around the teeth, inside the gums, and seeing if there's any deep pocketing. You're looking at the tissues, the type of tissue, is it thin, is it thick? You're looking at the quality of it. There's something called keratinized tissue, which is essentially a tougher tissue, which we like. We're looking at if the tooth is mobile, if there's bleeding, things like that. Radiographs, of course, so looking at x-rays, and then CBCTs, which are your cone beam computed tomography. That's going to be how it's become the gold standard now if you're going to be placing implants on evaluating bone, because it's not just, the radiographs are a 2D image of a 3D object. With our CBCT, we're getting that three-dimensional diagnostic tool that we need to be able to see how far the nerve is, how wide the bone is, you name it, we can get that information from the CT. Some instruments, there are a ton of instruments in perio, especially it feels like. There's different types of periodontal knives, the Kirkland, the Ocean Beam, Sugarman. You may notice these are all last names. There was this infatuation with naming instruments after themselves for a while in perio, it seems, but most instruments are named after someone, which in their defense, I guess if I came up with an instrument, I'd like to potentially name it after myself, maybe. But anyway, curettes and scalers are going to be your standard tool. At the minimum, as a general dentist, you will have a set of curettes and scalers in your office because that's what you're using to do your cleanings. If you're doing extractions, you have things that are called extraction elevators. You have forceps. This is just again a few examples of some of the instruments that we use, but there are a ton. Included some photos for you guys. So some of my favorites. So on the left here, we have what are called periotomes, and these are essentially elevators for extracting teeth, but they're very, very thin, so they're very friendly with the tissues. And perio, we're very respectful of soft tissue, and we try our best to maintain it and not disturb it as much as possible when we're doing extractions. And that this is one way how we can avoid causing any sort of damage, is by being mindful of not only the technique, but the instrument that we're placing in to actually remove this tooth as least traumatically as we can. And then on the right here, this is called a Castro Viejo, or just a Castro, as we'll say. And this is what we use for suturing. So it is amazing because you have free range of your wrist, as opposed to sometimes when you're using a needle holder, you kind of get limited with the how much the holder is actually going to open because you're using your thumb and your forefinger. You're kind of restricted in that sense. And it's essentially life-changing. I have to say, I've never, now if I ever pick up a needle holder, it's because I have to, not because I want to. But thankfully, these are pretty standard in for any periodontist. So you shouldn't have to, subject yourself to using a needle holder if you don't want to. Technology, I would say the CBCT scans, like I was talking about a little bit ago, because they're just very detailed and they help us analyze the bone and the space that we're working with in a way that you normally couldn't with a radiograph. So these are pretty great. Microscopes. This is me using a microscope the other day. Just kidding. But we do have some microscopes in the clinic, and apparently we're getting some new ones soon, so I'm excited for that. Microsurgery is its own beast. It is, as you can imagine, very technique sensitive, and there's a learning curve. But anyone, and I haven't done it myself, so I can't speak to it too much, but anyone I know that that practices it regularly says it's the best thing ever, is once you get used to it, which makes sense. I mean, the amount of detail that you can now see, how precise your incisions are, how your suturing technique improves, how your placement, it really is a really important tool to have. You just need to have proper training to make sure you get the most out of it. Lasers. There are a ton of lasers in perio. Where I'd say we probably use them the most frequently. The list here is just the different types, and really what's different is there's a lot that goes into the lasers, and it deserves its own lecture, to be honest. But it's a lot on not only the direction maybe that the laser is pointing at, but how what's the field depth of field that it can actually target. What strength are you using it at? Is it going to be attack? Is it going to be working on hard tissue versus soft tissue? What sort of feedback should you expect to get in terms of the tissues responding, where it's going to be hemostatic, meaning you're going to get well-controlled bleeding? Is it going to be burning the tissue, which we don't want to necrotic tissue either to a degree. So a lot of factors that go into it. And these are just some examples. The one that we have at Penn is there on the bottom right. It's called the Merida, and it's an ERIAG laser, and it has the capability to cut into hard and soft tissue, meaning I could just cut away some of your gums, and I could take a cavity out of your tooth. It's pretty strong. It's great. I don't do cavities anymore, but if I wanted to, that's what I meant. And let's see. We kind of talked about these a little bit, but the looking into a digital workflow, that's its own process. It's very different than the traditional way that you're taught on how to do a case workup. So understanding the different types of imaging you need and how to work with it from a software standpoint. The most simple example I can give you is just the file types. For example, when you take a CBCT, you're going to have a DICOM file. And then if you take an intraoral scan with any of these scanners you guys have seen in offices potentially or read about, that's going to be an STL file. And there's software that you can use to merge the two and create a lot of different things. You can make a wax up based on this plan or this merged file that you've created. You can create a surgical guide to help you make sure that your implant placement is very precise. It's really helpful in more ways than one. The microsurgical instruments, like I was mentioning before, can be a game changer, but you have to know how to use it, and there's a learning curve. So you just have to give yourself some wiggle room and time to practice, but it can make your surgeries very, very precise, and that's so important in perio. And then the materials that we're using every day, something new is being improved on, and it's exciting. You know, we work with a lot of great products. Some things I really love are from a regenerative standpoint is biologic materials. The two things I probably use the most are PRF and then the alternative, which to avoid the patient from having any procedure or any blood work done on them, which would be something like GEM21, which is a growth factor. With the PRF, it's really cool though, because it's chairside. You can basically take some blood from the patient, fill up some vials, take it to a centrifuge, spin it down, and you're able to use the fibrin clot that forms to pack into any areas that you're working on. If you're doing a regeneration approach, you might mix, a lot of times we'll mix our PRF with the bone graft in places in the site, and it's a very malleable, it now becomes very easy to work with in terms of the texture, and it has all of the patient's own growth factors. So the healing is optimized beyond compare. So it's a fun treatment option to offer the patient, and it could really help in the success of your treatment outcome. So important terms, again, a lot of these things I'm talking to you guys about, I'm barely, speaking to you about for 20 or 30 seconds. These can be hour-long lectures, and I'm happy to talk to you guys about it anytime if you have more questions, but just some ideas of words you'll hear: periodontal destruction, periodontitis, this is all related. Microbial dysbiosis, it sounds scary. It's essentially when you have a lot of the type of, we have tons of bacteria in our mouth, but there is healthy bacteria and there is bad bacteria. So talking about the loss there's now a loss of this balance in the good and the bad. And so that's when we start to see more destruction. Periimplantitis, so breakdown of bone around an implant. GBR and GTR, I talked to you guys about. I've used soft and hard tissue a few times. Dehiscence or fenestration, these are basically parts of bone that are missing. It could be a window of bone that's missing. It could be a whole portion of bone at the top or bottom, let's say. Osseous is another way of saying bone. Alveolar housing is another way of saying bone. Bone's one way of saying bone. So we have a lot of interchangeable terms as well. Okay, so let's jump into a case. Again, just trying to be mindful of time here. So sorry if I did through or flew through anything too quickly, but I'm happy to answer questions at the end. So this is one of my first cases that I got to do as a resident. And it was a little controversial because usually a first year shouldn't be doing an immediate implant, but the situation kind of called for it. It was a patient who really trusted me right away. He's also Spanish speaking and I speak Spanish, so he felt most comfortable in communicating with me. And long story short, I ended up having the chance to do this procedure, which was a really great experience. I mean, it had a lot of fundamental lessons within just this one surgery. So I'm gonna present this to you the way that you would speak periodontally, and I understand that some of you might not have um, all the terminology down yet. Maybe your dental IQ, if you will, is not up to speed yet. But just to give you an idea of how things sound, if you're talking to a periodontist, this is how it goes. But essentially, a 56-year-old male presents and he has a coronal fracture of number 7. The tooth is deemed non-restorable. The plan is to take the tooth out and place an implant. Non-restorable meaning this tooth broke down too far, so much that we can't restore it in any way. We can't put filling in it. We can't put a crown on it. It's too far gone. So for this treatment, we're going to be taking the tooth out and we're going to be putting a coax southern implant in. This is a very specific type of implant. I'll talk to you guys a little bit about. Only this company makes it, and it's great. It's very important to have, or it's important to know at the very least that it exists in terms of helping you have a few more options to provide to your patient in the case that you have certain restrictions. So by that I mean, I'll show you. But here the patient, obviously, this being number 7, this tooth fractured off. These other teeth were prepped already. This is all gonna be a bridge, but this tooth fractures off, and so we have to, of course, take it out. This is pre-op before we've done anything, and this is post-op. Uh, no frills sort of extraction because I focused on, again, fundamentals. I used those paratomes I showed you earlier. I used not micro instruments, but instruments that are meant to be more protective of the soft tissue. Aside from the peritome, we have something called exotomes, which are also elevators, very thin. Feel free to Google them. There's a lot of different kits that you can find, but the ideas are just they're thinner and they're longer, they're skinnier, they have different angles, so it really helps you alleviate and start to create that luxation that you need in the tooth before you can actually extract it without disturbing the bone or the soft tissue very much. So tooth comes out, we're able to get everything out in one piece, nice and clean. You can see the extraction socket there. We see a nice blood clot already forming at the apex there, meaning at the bottom of the site. And here we see intact. One way to, if you want to confirm that you've extracted a tooth completely intact, is with your finger. It's really a touch sensation, but you're just gonna kind of feel along the apex right here, and it's gonna feel blunt. I mean, it's gonna feel very smooth. You shouldn't feel sharp. If there's some sharpness, if you can see that it's broken in half, obviously it's broken. But if you're unsure, you feel for it. And if there's something that feels rather sharp, it's best to go back and double check you didn't leave the root tip at the end there. And then here's starting out with the implant. So with the southern, what's really special about it is that sometimes you're restricted by how much bone you have in placing an implant. And what happens a lot of times is if you don't have enough bone, you have to do an augmentation procedure. So kind of what I talked about earlier, where you have to do some sort of grafting, let's say, and build up the site. So theoretically, this patient, when we took the tooth out, in this area here on the buccal facial side of where the tooth is, the bone there was not enough bone where I could place the implant where I need it to be in terms of a restorative standpoint. So by that, let's go back to this photo. What I mean is this right here, hopefully you guys can see my cursor, but this right here is the screw hole. This is the angle that the implant was placed. So you can see there's 2 different axes. Or axi, whatever it is. What I'm able to do with using the southern coaxis is place the implant to make sure it's completely housed in bone, but still be restored prosthetically. So ideally, I would have, if there was enough bone, I would have placed my implant where this axis is, where you would screw down the implant. If I did that though, you would have a portion of the implant hanging outside on the facial wall. So if I can angle upright the implant a bit more, now it's getting closer to the facial aspect of the tooth, but at least, or more upright rather. But now what would happen is if I had to put the crown on, it's going to be sitting on the front side of the tooth, if you can imagine that. So with the co-axis, I've placed the implant in the axis I need it to be, but I can still put the crown on and actually insert the screw in a way that's aesthetically pleasing for sure, because you don't have a screw channel right on the outside of the tooth. And also from the restorative standpoint, the dentist or whoever's restoring it is able to actually place their crown and cover the whole area completely. Hopefully that makes sense to you. I can get into it a bit more otherwise. And this is right after placement, so it worked out. This again, this is one of my first cases, so my dental photography was not ideal, but in including this, I was just trying. Ideally, I would have shown you a photo where I wasn't retracting the upper lip, so you can see his natural smile. The point is, this patient had a tooth come out, an implant go in, and when he smiled, unless you were pulling up on his lip this high as I was, it would look like that nothing had happened. You would just see the crown of the teeth for this temporary bridge that the dental student had made. And so that was able to stay on, and that way it looked like it had a tooth in the meantime while everything was healing. So this is a cool case. The patient actually has already had the final the final restoration put in. I'll have to get an updated photo and include this for in the future if anyone wants to see, but everything, the whole bridge is in place and he's very happy, so it went well. All right, second case is somewhat similar in terms of the procedure that we started out with, but the approach is what changed. So this patient needed a tooth to come out and ideally would have liked a immediate implant. However, financially he was restricted, so that co-axis I just discussed was not an option. And so instead we did the grafting procedure. And similarly, the reason why the tooth came out was because it was non-restorable. So this is pre-op. Patient's hygiene is obviously not ideal at all. And we've definitely reinforced it, gone over it a ton, and he's gotten a little bit better, but still not quite where he is. We're having him in for maintenance regularly, and hopefully he'll get the hang of it soon. But in any event, this is what we were working with pre-op. And this is immediately post-extraction. It's the same thing. You can see the tissues are intact, clean extraction, tooth came out, everything looked good. On the radiograph, we could see that above the apex of the tooth was a radiolucency, meaning that if you're looking at an x-ray, right above the end of the root, there was just a dark black circle, which tells us that there's no bone there. Because usually in a radiograph, the bone is that whitish color that I'm sure you're all familiar with. So when you see something like that, that's considered pathology, you can expect that you want to see something else come out besides the tooth. And so we went ahead and only the tooth came out intact, but we didn't get any granuloma, which is what we would expect because it was such a what we call well circumscribed radiolucency. So it's very specific. We can see the outline. Nothing came out. So we knew something was left. So we did is design a flap. Basically, we went what's called sulcular. So you take your blade and just go around the teeth directly inside and directly inside here as well. And then we dropped what's called a vertical releasing incision right here on the distal side of the canine, just going straight down there. And that gives us ideal access to see the area we're working on. So this is what it looked like after, once we got everything opened up and cleaned. This is bone, and this is what's called a fenestration, when it's just a window of bone missing. This is what happened with from that granuloma, from that pathology that was present. It essentially eat it away at the bone. So this picture was taken after it was removed, but basically there was just a big chunk of soft tissue there. You can imagine it's a very tough tissue. You have to clean out. It's what we describe as fibrotic granuloma. That's typically what the terminology that we're using. And we got that cleaned out really, really well. And this here is just a periprobe just to show that there is that fenestration and that involvement. So then we put some bone graft. It's just this particulate material. Patient, was obviously some bleeding here, so that's what you see is mixing in with the blood, which is good. We need a good blood supply if we're going to get any sort of healing that we're looking after. So this is a good sign. And then this here is a membrane that we place over the graft material to contain it. This is pericardium membrane, but you can have a lot of different, excuse me 1 second here. All right, sorry about that. I feel like I'm in Florida again. It's like there's a hurricane out there. Um, so yeah, so this is the membrane. We use pericardium. There are a lot of different options on the market. This is really nice to work with. It was just very easy to manipulate and place over the area as we wanted. And then this is closure. So these sutures, this is immediately post-op, obviously. So we got all the tissue approximated as best we can. And we don't have the post-healing picture here. Again, I can have those in a future presentation if you guys wanted to see what that looks like. But the site has since healed and we've placed the implant and the patient's currently healing before we can go on to the final abutment and get the crown for him. So that case went well as well. All right, and just to wrap it up here, sorry guys, I know it's getting a little late, but just some advice for you all. Just, I can't say it enough, but remain positive. It's gonna be frustrating sometimes. It's gonna be difficult, but it's so worth it if you really love dentistry, if you really love any specialty that you come to find in it, stick to it, and it's obviously worth it. That's why so many people are dentists, and that's why so many people speak so highly of the profession. Also, remember to take care of yourself, whether that be working out or reading or traveling or whatever it is that floats your boat. Do that. Give yourself that nice little escape and that reward for the hard work that you've been doing, and make sure that you always do your best for yourself, because at the end of the day, I truly believe that hard work does never goes unnoticed, and it's a really nice feeling to know that you're serving people in a way that they can't provide for themselves. Not a lot of people have this skill set that you guys are all looking into to having. So make the most of all the experiences you have coming your way. And yeah, I hope you guys enjoyed, and hopefully I didn't scare you away from perio. I'm happy to answer any questions. And that's about it.
That's awesome. Thank you so much, Dr. Rascon. So we actually have a couple questions here. One of them, the first one is, what are your thoughts on applying to dental schools abroad?
I've never been asked that question before. You know, to be honest, I can't speak to it because I don't even know what that would look like. I also don't know if I'd advise it, because what the licensing and training you get there is not going to be transferable. You know, more often than we have, if any of you are familiar with PASS, the PASS program, a lot of dental schools have them, where international dentists come to the States and they go through 2 years of dental school here with us to get either their DMD or DDS and have a US license. I don't know that anything like that exists overseas, and I've never really heard of anyone going that way, you know, if you will. So I can't speak to it too much. I will say that it is going to be difficult because you're going to have to essentially redo training if you want to come back and work here later.
Gotcha. Thank you so much. I know you don't have that much experience on it, but that was like a really good take on it. So another question we have here is, what piece of new technology took you the longest to learn and you feel comfortable using?
Also a great question, and honestly, it's still learning all of it. I'm a second-year resident, and it's crazy. There's so much to learn every day. You feel a little bit better about something, but then you also realize that you didn't know that other thing. So it's humbling, to say the least. I think one of the technologies I become the most comfortable with, that I was a little intimidating at first, would be the PRF, because you're not trained to do phlebotomy and venipuncture, and you're literally chairside drawing blood from this patient's arm. And it's really interesting how, you know, as periodontists and as dentists, we're used to bleeding in the mouth and we don't seem to be bothered by that. But as soon as it's somewhere else in the body, we all get a little, you know, a little more cautious. But I think it's a lot of fun to do, to be honest. And the results that you get by working with it are, so, to me, so worthwhile, and having that skill set. So I focused for myself. I focused on getting really good at it, as good as I can, and doing it as much as I can. So I would say PRF.
Awesome. Thank you so much. Now, the next question is regenerative materials safe for everyone? And does it create complications if you have, chronic diseases?
What was the first part of the question? I'm sorry.
It was, sorry if it's a little bit loud. It's the person asked, is regenerative materials safe for everyone? And does it create complications if you have chronic diseases?
So yeah, materials are overall safe for everyone. Whatever we use is FDA approved. There's of course theoretically always some potential risk. The nothing where it would affect you systemically necessarily. So for example, one complication that you'll see is what's called membrane exposure. So a lot of these membranes we use are meant to be completely covered with your gum tissue. And if you had what's called dehiscence, so when the tissue's healing, it starts to separate, and that membrane that you use is now showing, it can necrose, essentially meaning die out, and it can look a little nasty and be, some swelling for the patient. That's really, thankfully, the gist of it. For the most part, because you kind of at that point have to just clean it and let it heal again. Now, in terms of patients with any significant medical history, it can play a role in if you're going to use something or not. So most notably, if you have an uncontrolled diabetic or a heavy smoker, a lot of these procedures just aren't going to work. They're not going to heal adequately like we want them to. A lot of the materials you place are going to fail because they're not getting the appropriate nutrients that they need. And that's the one thing I'd say to keep in mind with anyone with any sort of chronic illness is how is that going to affect the healing? That's really the name of the game with these surgeries that we do.
Sounds good. Thank you. Another person, or I think it's the same person, asked, do you feel implants are becoming more accessible?
Accessible. Um, yes, I mean for sure they're definitely getting closer and closer to being. I don't know if I'd use the term standard of care. I think a lot more patients are aware of them now, and a lot more patients want them because they experience what it's like to have a removable denture or a complete removable denture, or whether it's complete or partial, rather. They just realize it's not comfortable and it's not sustainable long term. It ends up being really annoying more than anything else. So it's definitely an option pretty much anywhere you go. Now, accessibility in the sense of finances, I think they're trying to get better at making it something that's attainable. At Penn specifically, we have we don't have it anymore, but we had a crazy grant program where the patients were paying a, a few $100s for the implant and the crown, which is unheard of. Typically, it's at least $2,000 to get both. So that was a nice service I think they had for the community, and a lot of patients took advantage of it.
Sounds good. Okay. And our final question is there anything you wish you would have known or learned while you were in school?
In school, college, or dental school, or residency?
Maybe you could give a bit of both. This person didn't specifically mention it, but I think it'd be nice to, know about both.
Sure. I think as a college student, I wish I knew that I liked dentistry sooner. And I really wish I knew I liked perio sooner because I would have focused on being around periodontists as much as I could. I think seeing private practice is so valuable. It's absolutely night and day compared to a dental school experience. Even now, I try my best to get into private practice offices when I can. It's just really hard with the amount of time we have. So if you have an idea that you know what specialty you want to do, start shadowing them now as much as you can and really pay attention. If you don't, maybe just start shadowing all of them here and there when you can, just to start getting an idea. But I wish I did more shadowing in both, to be honest, in college and dental school. Obviously, the amount of time we have to do that is tough, but it would have been nice to get even more exposure just to get a little more used to the day to day of what that looks like.
So unfortunately, it looks like that's all the time we have today for questions. Dr. Rascon, thank you so much for joining. And I want to thank all our viewers for tuning in today's session. On that note, I wish you all have a great rest of your day. Thank you so much.